introduction. So today I'm going to talk about anxiety and major depression. Wait, let me go to the first slide. Yeah, so I've named my talk today, I Am Fine, Depression and Anxiety, the Silent Killer. Why I am fine is because I think many of us, many of our patients and also us, when we don't feel too well, when we feel a bit sad, most of the time when people ask us, we do say we are fine, right? We are not so keen to talk too much. So I think it's a Malaysian thing or an Asian thing. We always just say we are fine, hoping that the people around us would stop asking further questions. So yeah, let's before we go on further, I'd like to encourage you guys to just ask questions along the way. You don't have to wait till the very end, because I think it's also a Malaysian thing that we just wait and wait and wait. And when the talk ends, we all disappear and we forgot our questions, or we just want to go for lunch real quick. So we just forget about our questions. So I'm all right if you just ask questions along the way. Interrupt me throughout the talk, it's fine. So when you do have a questions on a particular slide or on a topic related to the slide, just ask your questions on the spot. I'm completely fine with that. Let's not make this too formal. As Laura also mentioned, that the subsequent few topics would be a bit more technical, just a bit. Yeah, but let's try to make it as informal as possible. Just interrupt or share your views along the way. I'm completely fine with that as well. So without further ado, we will just start with our topic on depression and anxiety. So we'll go through a few statistics first before we dwell much in depth into depression and anxiety. So according to the World Health Organization here, over 350 million people worldwide are suffering from depression right at this very moment. Wait, let me take this thing away so I can see the words. Yeah, so according to the CDC, 1.9 million children are struggling with depression. And out of this staggering number, 50% of all mental disorders start as early as the age of 14. An estimated 275 million people worldwide live with anxiety disorder. Out of these 275 million people, most of these anxiety disorders are phobia-related disorders. So you have phobia towards height, phobia towards insects, these are the main chunk of anxiety disorder population, followed by social anxiety disorder. And then the ones that we commonly see, generalized anxiety disorders. According to the World Health Organization and the suicide worldwide, nearly 800,000 people die by suicide each year. And this is a very sad statistic whereby every 3 seconds, someone thinks of taking their life, and every 40 seconds, someone actually dies by suicide. So I think ever since I started talking, you guys are still quiet. It has been about 3 minutes, 4 minutes. So out of these 3-4 minutes, about 4 to 5 people around the world has actually died by suicide. So this is very sad, and that's why I think these courses are being organized to create more awareness about mental health disorders. So suicide is the second leading cause of death for 15 to 29 years old worldwide, and the fourth leading cause of death for adults ages 18 to 65. Malaysia detected its first case of coronavirus on the 25th of January 2020. And ever since then, I think ever since then, Malaysia has got into multiple lockdowns, right? To control the rise of COVID-19 cases, and we're still doing that, even though we are going into an endemic phase. And this has not just impacted the economic stability of our country, but it has also left many, many people in our country mentally broken. We'll just like to talk about the impact of COVID-19 just briefly on mental health, just to highlight how much problems COVID-19 has actually caused on mental health in our community. So the pandemic has actually cracked open the facade of mental health. Rates of psychological problems have markedly increased during this pandemic. Depression, anxiety, grief, PTSD, suicide, use of substance, alcohol and illicit substance have also been on the rise. violences such as domestic violence and child abuse have also been so much higher, have been in such greater rate as compared to before the pandemic. According to statistics, a total of 145,173 distress calls were reported by government agencies from March 2020 to May 2021. The calls have gradually decreased lately as vaccination has been introduced, death rates has decreased, but during that period of time, 85.5% of the huge chunk of calls were actually related to mental health issues. Malaysia recorded an astonishing figure of 468 suicide cases in the first 5 months of 2021. This is an average of about 3 cases a day, nearly doubling the rate in 2020. Yeah, so enough of statistics. I think that is just to highlight how bad the COVID-19 has actually affected our country in the mental health perspective. So looking at this diagram, you can see that the faces of people who are depressed and suicide are actually more or less the same than those who appear happy, or actually they appear even more happier. And this is what we call in psychology or psychiatry defense mechanism, whereby people around us, especially those who are depressed, sad, anxious, they tend to overcompensate, or they put on a mask, a facade, showing that they are actually happy, but deep inside that they are actually suffering from a lot of challenges. So it is our duty to explore more, be more sensitive and empathetic to find out what really they are going through. Are you guys okay so far? Do you have any questions? Am I talking to myself? Hello?
There are no questions in the chat box so far, Dr. Mervyn. Maybe they still need some time to warm up.
Okay. All right. While you guys warm up, we will move on to the next slide. Yeah, so according to J.K. Rowling, this is the famous author, right? Harry Potter, I'm sure you guys know. Depression isn't just being sad, it's feeling nothing. It's not wanting to be alive anymore. This is her own interpretation of depression. She was a survivor of depression, and different people actually, if we look at the patients that we have that have actually gone through a depressive phase, or that are still going through a depressive phase, they go through different symptoms. Some feel sad, some feel agitated, some get angry a lot easily than before. You know, they go into temper tantrums a lot easily with their children, which they didn't experience before. Some just want to be left alone. They isolate themselves from their colleagues, from their friends. Some don't sleep well at night. Some have just constant preoccupation with negative thoughts. Some just have very low self-esteem. So depression isn't just about feeling sad. There are a lot of actually different symptoms that are experienced by different people. Moving on, I'd like to introduce you to this character. Let's call her Miss DP. So Miss DP is a 21-year-old woman. She's a daughter. She's a girlfriend to a boyfriend. Yeah, she's a university student. She's a volleyball player for her university, and she's also a pianist in church. Seems like a very typical young adult, right? Seems like she is also living her dream. Ooh, who did that? So DP is, these are things that DP's friends mention about her. So DP is the kind of person who lives life to the fullest, who believes anything's possible, and who laughs from the belly. None of DP's friends mention that DP is the kind to suffer from depression, and none of DP's friends says that she is the kind who appears anxious. Okay, so what actually goes on in DP's mind? What does she actually feel in the inside? DP's depression has actually been with her for the past 9 years, and she's only 19 now, so that's about nearly half of her lifetime. So the brain is just an organ like any other organ in our body. If you leave depression or anxiety without treatment, just like any other physical disorder, hypertension, diabetes, cholesterol, it does not go away on its own. Sure, pharmacies, right? You guys will be giving out simvastatins, your atorvastatins for your cholesterol and your antihypertensives, because patients need these medications to keep their hypertension and their cholesterol under control. And just as people die as a result of untreated physical illnesses, people also die as a result of untreated mental illnesses. Suicide happens when the ability to cope with pain is just too overwhelming. And people don't kill themselves, it's their illness that kills them. It's this mental illness that kills them. People are actually the victims of suicide. The suicide is what kills them. It's the illness that is untreated that is what is killing them. So this is DP's story. Behind closed door, DP has been hurting herself as well by making superficial cuts all over her bilateral forearms. Every cut she makes brings her back to unpleasant times where she was too overwhelmed by her depression, too overwhelmed by her anxiety, and times whereby she has no one to turn to, no one to seek comfort from. DP's internal pain, whenever she cuts, is manifested and released through all these physical cuts, these physical wounds that she induced on herself. So however, the cuts that she made, the pain that she feels physically are just temporary. And DP would be swamped back by her negative emotions and a great amount of guilt and regret after she performs this self-harm behavior. So how on earth did DP reach this point? If you remember from the talk previously by Dr. Amanda, she mentioned that depression is like baking a cake, right? Yeah, so in a cake, you have different ingredients. I'm not a baker, but I assume you need flour, eggs, butter, sugar, maybe a pinch of salt. Yeah, I suppose so. Yeah, so depression and anxiety, it's the same. They are very complex. And depression and anxiety are more often than not multifactorial. Like your cake, they have multiple ingredients. Same for depression, anxiety, multifactorial. So before we move into the causes of depression, any questions so far? Can you guys hear me clearly? All right. Okay, great. If you do have questions, just ask. Yeah. The causes of depression, multiple causes, and there might be even more causes than what you see on the screen. The red arrows here actually shows the causes that perpetuated the depression in DP's case. So remember our character in this presentation, yeah, DP. Everything goes back to DP. So in DP's story, we could start by taking note that her father also has underlying major depressive disorder with anxious distress. So father is still seeing a psychiatrist and is on antidepressants, but at this very moment, his symptoms are relatively well controlled. So genetic causes there, right? Yeah, number one here. DP's father has also major depressive disorder with anxious distress. Then there was also the loss of DP's grandmother when she actually entered university during her first year. DP was very close to her grandma, as her grandmother was the only female figure in DP's life when she was growing up as a child. So this would be stressful events, I suppose. Grief of someone very close to DP, her grandma. So what happened to DP's mother? Why did DP grow up with only her grandmother as the only female figure? DP's mother separated with DP's father ever since DP was a 7-year-old girl. There were constant arguments, there were constant fights between her parents when DP was a young girl. She grew up in a chaotic, non-nurturing, and quite a violent household ever since she was a child. And up to this very day, DP still blames herself. She still has lots of guilt that perhaps she was the cause of the separation of both her parents. So this would be past traumatic events experienced by DP, you know, all the violence, the chaos during her childhood, and also chronic stress, because up to this very point, the constant guilt and blame that she puts on herself for the separation of both her parents. So these could be the possible causes of depression in DP's case. Next. let's look at some studies. This is a study not so new, done in Switzerland 2003, just highlighting causes of depression, you know, real life causes. So in this Angmo country, you see causes of depression here: difficulties within the family, difficulties with a partner, occupational stress, more stress, traumatic events, and also, you know, depressive disorders and other unspecified illnesses. Moving on to our next slide, going to something more local. So this is a study done in Malaysia in 2017, more recent study. I think it studied 3 states: Selangor, Penang, and Terengganu here. And it highlighted that, I'm just showing you why this study, because it's mentioned in our previous slide that occupational stress is number 2, right? So in our local study, business owners reported more depressive symptoms. Just a fun question. According to this study, what occupation do you think have the least, causes the least depression or depressive symptoms? Yeah, this is not a hi-fi question, but anyway, this study concluded that housewives actually has a negative association with depression. So I guess most of you female pharmacists are in the wrong profession. Yeah, so yeah, but this is just one study. And yeah, it mentioned that housewife has a negative association with precipitating depression in, you know, among the housewife population. But I'm sure housewives also has their own level of stress, right? Especially those with lots of children or children with at a young age. All those actually are a different level of stress for them. Another study done locally, this also shows us different causes of depression in Malaysia. And if you see the difference between our study and our depressive causes compared to the Angmo country in Switzerland previously, our Asian population actually grades failure in achievements and examination at a higher percentage of depression causing compared to relationship as compared to the previous study done overseas. So I don't know, maybe we're more competitive, we're more, you know, Asian-ish, making us view failure in achievements and examination at a more cause of depression as compared to relationship-wise. But this is another study in Malaysia, and this is also another one focusing on Selangor itself. And this one is more balanced. It has causes of relationship, you know, unhappy relationship, and also stress at work, and also, you know, work stress and other forms of stress causing depression. If you realize the studies overseas in Malaysia also mentioned that chronic diseases predispose people, our population, to depression as well. So I've also put the next slide in this slide, which shows you, because we're all in the medical field, right? So this slide actually shows us what kind of diseases predisposes patients to depression, which diseases are more prevalent to causing depression in patients. So if you look at this slide, it's the cardiometabolic disease. I'm not sure whether this surprises you, because most of us view this as, you know, common. We see a lot of patients, I think, every day. It has become so common that we see patients with underlying hypertension, diabetes, cholesterol causing, you know, heart diseases, and all these are cardiometabolic disease. But we actually don't realize that this group of population are the ones that actually has the highest burden of depression and anxiety among the other populations, comparing to those who has underlying cancer, who are not far behind those who have neurological disorders like strokes, you know, epilepsy illness, dementia. But all these actually are, they don't, not as high depression causing as those with cardiometabolic illnesses. Anxiety causes are actually more or less the same as your depression causes. The red arrow shows the cause that may be experienced by DP, causing her to also have anxiety symptoms. This is an article highlighting the risk factors for anxiety disorders. it's more or less the same like your depressive disorders. As you see, they are like concurrent. I think it's written here somewhere in the article that major depressive disorder is also a risk factor for those patients who actually come up with anxiety disorders eventually. Before we go into symptoms of both depression and anxiety, do you guys have any questions?
Dr. Mervyn, I think there are some questions in the chat box.
Okay, looking now. Oh, second. The line here is very bad.
Why don't I just read it out to you?
Can.
I think someone asked, is a perfectionist personality a risk factor for anxiety and depression?
Good question. I think not so much. I guess there are truth behind this statement as well. Previously, I would say that if a person has a perfectionist personality, they would be more predisposed to OCD sort of disorders, obsessive compulsive traits, or predisposes them to more obsessive compulsive disorder. Why I say this statement is partially true is because because OCD was previously put under the anxiety umbrella, but now it has actually been separated from the anxiety disorder umbrella, and it's a disease entity on its own. But why I say it's partially true, it's also because even if you have OCD, the distress usually causes a lot of anxiety and perhaps depression in the patient. So perfectionist personality would most probably predispose a person to more OCD traits and disorder, which would then cause them to have anxiety and depressive symptoms. So yeah, true and false to this statement, but yeah, OCD would be more prevalent among those with perfectionistic personalities. Yeah, if that answers your question. Are there any other questions here? No.
I don't see any other new questions in the chat box, Dr. Mervyn.
Okay, so we'll go into symptoms. This is very technical, and like I mentioned earlier, it actually depends more on the individual. But theoretically, I think it's important for us to at least know common symptoms of depression. But always bear in mind that different patients come with their own characteristic and signature symptoms. So the red arrows here again shows the symptoms that is portrayed and exhibited by DP. So a year into DP's grandmother's passing, DP realized that things were not quite right. DP felt a constant feeling of sadness. She also realized that she became increasingly anxious when she had to make simple decisions. Things she previously enjoyed, she did not want to do any longer. DP got angry easily, and she had snapped at her friends in several occasions over extremely minute matters. DP was becoming very withdrawn, very unlike her previous self. She preferred spending a lot of time alone in her room. DP's mind felt muddled, and concentrating in class became a very huge chore for her. This was very unlike her because she was a good student in the past. She saw a mild deterioration in her academic grades during her last examination. So all these characteristics of DP, all these symptoms of DP actually are indeed red arrows. Something more technical. Oh wait, it's not moving. Yeah. So this is according to what we are using here in Malaysia, our DSM-5 criteria. ICD-10 more or less the same symptoms. So this is rather technical, but it's good to know. This is theoretically what we expect to see patients with a major depressive disorder. Theoretically 2 weeks, daily symptoms, should have depressed mood and or loss of interest, the two bold ones, followed by the other non-bold symptoms, weight gain or weight loss, insomnia, hypersomnia, fatigue or loss of energy, worthlessness, hopelessness, difficulty concentrating, and at extreme and severe states, they start having recurrent thoughts of death and suicide. These, on the other hand, are physiological, cognitive, and behavioral symptoms of anxiety. Anxiety is quite a complex disorder with a lot of symptoms, as you can see portrayed in this slide. Patients can come with any symptoms, especially lots of different physiological symptoms. These physiological symptoms are actually triggered by your sympathetic response. You know, when you feel triggered by fear or anxiety, these are what we experience even as, you know, the general population. And when we experience this, it starts affecting our cognition and our behavior. So this is the DSM-5 criteria for a panic disorder. I think in the questions that Laura gave me prior to the talk, there was one question which asks us to differentiate between a panic attack and a panic disorder. We have to bear in mind that it's called a panic disorder because it has already reached a state whereby it affects our daily function. That's why it's called, you know, there's a term disorder. Panic attacks could happen to the normal general population, not necessarily patients. And panic attacks, if uncontrolled, or if they do get to a stage whereby they increase in severity, they increase in intensity, and patients start having recurrent fear of subsequent attacks happening in the future, then it may become a panic disorder. Another thing to take note is that in panic disorders, why it becomes a panic disorder from a panic attack is because those with panic disorders usually they, you know, the anticipatory anxiety, the recurrent fear of a subsequent panic attack happening would cause them to be very hyper aroused. So it's a cycle. So this constant fear of the subsequent panic attack happening, this increase in hyperarousal actually cause an increase in the frequency of another panic attack happening, you know, if it makes sense to you. It's like a cycle. So you fear the next attack happening. So your brain starts to be very hyper aroused, like, oh my gosh, another attack is going to happen. So this fear and this constant preoccupation that another attack is going to happen actually precipitates the next panic attack. So increasing frequency and intensity of panic attacks eventually leads to a panic attack becoming a disorder. So these are the DSM criteria for generalized anxiety disorder. It's very technical. I think you don't have to memorize it. Just know the symptoms are, you know, what kind of symptoms they are. And if, yeah, not, I wouldn't say it's not important, it's important, but then you don't have to memorize it because it's, you can Google it, it's there. Yeah, unless you're asking for exams, that is. So self-harm and suicide, we're talking about this because DP harms herself, right? So self-harm is one of the strongest predictors of suicide, including among older people. Individuals who have self-harm are at much greater risk of future episodes of self-harm and suicide compared to the general population. The risk of suicide is elevated by between 30 and 100-fold in the year following a self-harm, and the risk persists. So I think the last statement here is very important because it highlights how severe and how alarming it is when we detect a person or a patient or an individual or a friend that actually self-harms themselves, that you know, copes by harming themselves. Because if you see that they harm themselves, the risk of a suicide is elevated by 30 to 100 folds in that same year. So it's important to note this because I think self-harm has become quite a trend lately. So many, I'm sure some of the friends or even family members, you know, cut themselves just to cope with the stress that they are going through. And sometimes we label them as seeking attention, we label them as poor coping, but there's a lot more actually going, a lot more happening, a lot more struggles happening in them than just wanting to seek attention. Because this might be a cry for help from this population, and if we don't actually help them at this point of time, this self-harm behavior may end up as suicide. So yeah, it's important to take note of this. Okay, question? Does self-harm, question, I'm going to the question, yeah? Does self-harm always mean a desire to die? I would say no. Based on experience and also on studies, self-harm usually is a cry for help in most patients. So it's, if you look into the iceberg phenomenon, self-harm would be at the tip of the iceberg, you know, like your Titanic, you know, the Titanic crashed into the tip of that iceberg. Yeah, so self-harm behavior, depression symptoms, you know, crying, isolating themselves, all those are at the tip of the iceberg, including self-harm. So it's standing up there, but you don't see the bottom. So what's standing up there are cry for help. These are symptoms that patients are portraying, friends are portraying to say, help me. And if we don't actually explore what's at the bottom, we don't know what's happening in them. Like if we go back to DP's case, all the symptoms that she portrayed, including her self-harm behavior, these are all cries for help. But if we actually study her, get to know her better, we get to see why is she crying for help? And we get to help her, we get to go to the roots and help her from there. So I wouldn't say that self-harm is a desire to die. I would still stick to the opinion that self-harm is a means for patient to cry for help. And it's later we'll go into our role, what we can do actually to help these patients. Next question, will patient with self-harm turn to harm other people? Rarely. We are talking about depression and anxiety. So based on our talk on depression and anxiety, patients with self-harm behavior in these two conditions, depression disorder, anxiety disorder, they rarely go from harming themselves to harming other people. Okay, does this mean all self-harm people should seek medical attention? What do you think? Wait, let me see. Sorry. Yeah, Mu Chiu Pin. Hi. Does this mean all self-harm people should seek medical attention? I would say yes, based on this slide. Because if you look at this slide, the third statement here that, you know, bear in mind that we're talking about self-harm in the context of depression and anxiety here, not self-harm in the context of, you know, other psychiatric illnesses. If you're talking about schizophrenia or bipolar or substance-induced, it might be a bit different. But in the context of depression and anxiety, I would say yes to your question, because in this context, the risk of suicide is elevated by between 30 to 100-fold in the following year. So if you don't actually treat the root of the self-harm, which is in this context, depression and anxiety, they would actually go into harming themselves in a more drastic way and eventually may lead to a suicide attempt or a completed suicide. So yes, they should seek medical attention. Oh, now my mouse is not working. Okay, wait. How do we identify someone who is attempting a real suicide or seeking attention? Refer them to us. We don't want to label people as seeking attention right from the very beginning. So if they do self-harm, a lot of these patients who self-harm sometimes do have an underlying personality disorder on top of the depression that they are exhibiting. So whether or not they have this personality disorder, it doesn't matter because we still want to treat them. Yeah, so we don't want to immediately label them as seeking attention or attempting a real suicide. Self-harm is self-harm and self-harm is not healthy. So that's what we want to treat. Yeah. So self-harm can be tension or is it okay? Yeah, I think we covered that as well. So bottom line is, once they self-harm, it may be a personality disorder. Usually the borderline personality disorder, they hurt themselves. Most personality disorders actually has comorbid depression as well. So they come with depressive symptoms, and that is what we want to treat. We try not to label them as seeking attention right from the very beginning, but we try to treat them with what psychiatric illness they have. So try not to actually think about them having attention-seeking behavior from the very beginning, because it's not too healthy that way. Yeah, we'll just go on. Maybe we'll answer more of these questions later on. Laura is keeping time. Check. Yeah, so DP eventually sought help and gradually felt better. She visited a government clinic and was suggested a course of cognitive behavioral therapy. So this we'll go into later as well. As time progressed, DP's depression got better, it lifted. She could laugh again. She could enjoy doing things. DP could concentrate in class again, and she started to engage with her friends once again. So it was an enormous relief for DP. Question 1. No Slido, no time to experiment on that. Maybe you guys can just respond in the chat room. Is it common for a major depressive disorder or anxiety disorder to recur after complete recovery in symptoms? Like in DP's case, she went for a course of cognitive behavioral therapy, which we would roughly touch on later, and her symptoms appear to get better. So is it common for these symptoms to come back after a complete recovery? Can just put in the chat room. Do respond. Yes, no. See, I don't know. Sorry, no Slido. Okay, lots of A's. All right, great. So I think we will just go on. So majority of you said yes, it is common. Oh, now my slides are stuck again. Okay, yeah. So yes, it is quite common, and we'll look into a study later. But unfortunately for DP, the depression did return. A few months later, DP started feeling under the weather again. DP thought that she was just coming down with something, and no, it's not COVID. Yeah, the depression returned. This time the descent was much more rapid, and it hit DP much harder. DP could not do the simplest things. A trip to the supermarket was so overwhelming for her. She felt so tired. She stopped checking her mails in her emails. She had no appetite. She just wanted to sleep all day. She tried to keep up with appearances, dress up to go to class, dress up to meet her friends, but it was just so much work for her that she started to avoid everyone once again. So DP just seemed to have shut down. According to this study, what you guys answered just now, most that the symptoms do recur, it's correct. Just focus on the one that are underlined. Yeah, it's to save a lot of time. So 70% of subjects experience remitting symptoms within 6 months. Same like DP's case, right? She felt well. However, 40% relapse over the subsequent 15 months. So whether or not they continue on with treatment, whether or not there are new emerging stresses, relapse is actually quite common. However, DP's parents got concerned about her symptoms, and they brought her to see a psychiatrist this time. So DP was then diagnosed with depression with anxiety symptoms. She was also given a questionnaire to gauge the severity of her depression. Her answers confirmed that it was indeed severe. She was then prescribed with antidepressants and concurrently another course of cognitive behavioral therapy, this time under a psychologist. We're going into the management of depression and anxiety now. This is the front cover of our very own clinical practice guidelines of management of major depressive disorder. It's quite new. It was published in 2019. This is the second edition. Unfortunately, we don't have a CPG for management of anxiety disorder, but bear in mind that the same antidepressants that we use, have dual functions, so they also act as anxiolytics as well. Check. Does ADHD? Yes, it does. It does. Can have comorbids once the child grows older into adolescent or adulthood. They have very high rates of comorbid depression. So yes, they do. Sorry, this computer from the office is very old, so it's a bit laggy. Okay, next question. Are the antidepressants or anxiolytics first-line treatment in the management of patients with major depressive disorder or anxiety disorders? Okay, this is no Slido again. You have to manually put in the chat box. Yes, A, B, no, C, I don't know. Let's see. Oh, we have a variety of answers now. That's great. Okay, so we have A, B's, and C's. Some of you are very honest. You put C. Oh, and more C's are coming. Okay, anyway, all right, we will stop there. So based on our CPG, remember the CPG that I mentioned earlier. Sorry, yeah, this CPG. This is from the CPG, yeah. Just bear in mind that the CPG is about major depressive disorder, but it does treat anxiety disorder as well. But specifically for major depressive disorder, in our CPG, they divide the severity into mild to moderate and moderate to severe. Red box. Everything that you see in red and underline, those are the important things. You just focus on those things. If not, there are too many words. So if it's mild to moderate, you see that it's plus minus pharmacotherapy, and moderate to severe, pharmacotherapy is first line. So the answer for the previous question would be no, based on our CPG and based on the severity. It's based on the severity of the depression lah. So if it's mild to moderate, you can choose to start or not to start your pharmacotherapy. It's not wrong. But if your patient has moderate to severe symptoms, you would want to put pharmacotherapy as first line. So if it's just mild to moderate, you want to focus more on psychosocial intervention and psychotherapy. And if you think that they would benefit from pharmacotherapy, you can start pharmacotherapy. But if you think that they would not benefit much from that, or you can actually buy some time to see whether their symptoms improve on just focusing on psychosocial intervention and psychotherapy, then you can also focus just on that. Psychosocial interventions are referring them to our occupational therapists, social worker, trying to solve whatever social issues they have, financial issues, or if they are, they just want to be cooped out at home in the room, you refer them to our occupational therapists to find activities for them to do to boost up their self-esteem. So all of these activities are under psychosocial intervention. Psychotherapy, on the other hand, are referring them to psychologists, clinical psychologists, or even the psychiatrists, and we do different forms of therapy on the patient, which we'll touch on later as well. In psychiatry, psychology, we usually want to treat the person as a whole, the biopsychosocial spiritual approach. So biologically are all the medications, psychologically, like mentioned earlier, all your counseling, your different forms of therapy, and social-wise would be referring them to occupational therapists, the social worker, to treat whatever underlying stressors that they're going through. Questions? Okay, thanks, Amanda. What's the difference between, oh, I already mentioned that, right? So just wondering, normally patients in the clinic or hospital would be moderate to, it depends on the patient actually, but even if they are mild, you can actually refer those that are mild to moderate. The psychiatrists will not start, if they are comfortable enough, the psychiatrists might not start any medications and intensify more psychological and psychosocial support. Yeah, so but the huge chunk with moderate to severe, we will start them on treatment and also at the same time concurrently activate psychosocial and psychotherapy. Comparatively to patients who seek help themselves. Oh, okay, this is the question just now. I suppose if you have the support from family members, this would be the, I think this question has two parts, right? Patients who are brought by family and patients who refuse to come, have no insight and are forced to come and seek treatment. I would say that those, I mean, if you compare these two groups of people, those who are willing to come, patients who are willing to come, these are the patients who have already emotional insight, that they know they are ill and they know they need treatment. Plus, they have the good support of their family to bring them for treatment. So this would definitely have a higher success rate and effective treatment. Those who are forced to come in for treatment by family, I think the main issue here is insight, that the patient has not much of an insight. Most patient has intellectual insight, but no emotional insight. Intellectual insight is insight whereby the patients know about their illness, but they refuse to seek treatment because they think that the illness, might go away on its own. Emotional insight is coming to acceptance that they have an illness and they need help to get them feeling better. So in this sense, we will definitely, those in the first group would have a better effective treatment. But having said that, we do not want to put the second group to a disadvantage, because the whole aim of therapy is to create a good rapport and to build up this insight in this patient. So they might have no insight at all, they might have just intellectual insight, but with continuous therapy and with continuous rapport building with the patient, we try to build up a emotional insight with the patient and also a good therapeutic alliance with them. And hopefully with that being done, this patient also continue treatment and get better eventually. Chin YY, I know you. Wait now. How to determine the severity? Easiest way is by scales. Scales can determine severity. Refer to the psychiatrist or the psychologist. We have scales to do, but we are clinicians. We don't actually depend 100% on scales. It's also based on the patient in front of us. I think it's always very important that scales are just to guide us, but when patients come to see us, we treat the patients as humans. So scales are just secondary. So how to determine severity? It's, to me, mostly by clinical findings. So different patients, different symptoms, and based on these symptoms, we determine the severity. Scales are secondary to support our diagnosis later. Is there any online counseling service help with those? Yes, there is. Actually, even before the COVID, actually, there is Befrienders would be one that is, I think, quite famous nationally. But if they don't want to call, they prefer to text. There are other more artificial intelligence apps that is still free now, known as the WeBot. Maybe we will, once this talk ends, I will just put it in the chat later. WeBot is a free app that you can actually go to, and this robot actually provides cognitive behavioral therapy, brief cognitive behavioral therapy to the patient. So you can actually try that as well. But this robot is very smart. So once they realize that they can't actually help the patients and patients have very severe symptoms, this robot actually advise the patients to go and seek help in the hospital. So you can call Befrienders, call MHPSS. I'm sure different centers have different mental health support, psychosocial support group that provides maybe email or calling services. You can try that as well. Or if you're shy to talk to people, try WeBot. WeBot is quite helpful as well. Okay. Oh dear. If death is their final wish. I think this goes back to the iceberg phenomenon. Why people want to die? There's a reason behind that death wish. So we have to find out the cause and then try to work out from there. Yeah. So let me go back to my slides before Laura screams. Oops. Yeah, so do antidepressants, anxiolytic really works, or is it a hoax? I think this is your field and you would know this a lot better than me. So neurotransmitters. So brain cells communicate with each other via these chemicals called neurotransmitters, right? And I think there are 4 main neurotransmitters that we are all aware of: the norepinephrine, the dopamine, serotonin, and acetylcholine. And these are the 4 main ones that are actually at very low levels for patients who have depression and anxiety. And when we take antidepressants and anxiolytics, they actually raise the levels of these neurotransmitters, making a person's mood increase. So they actually feel better, feel happier. So this is a brief diagram that shows you the healthy synapse of individuals and also the synapse of a depressed person. You guys know this a lot better than me. Yeah, so look, healthy individuals, more neurotransmitters, larger concentration of receptors. Depressed patient, lesser receptors, lesser neurotransmitters. The aim of antidepressants and anxiolytic is this yellow thing. So once the patient takes the medication, it actually increases the neurotransmitters in the synaptic cleft, and then it increases the mood of the patient. Yeah, simple, right? Simple but complicated at the same time. These are the list of antidepressants, anxiolytics, not complete list, but this is the best I can find that are available in our hospitals. There's actually more. SSRIs, I think you have fluvoxamine as well. SNRI, you have your Cymbalta, your desvenlafaxines. Mirtazapine is here. Amitriptyline is quite old. We rarely use it now. Still use it sometimes, but not so frequent because of the side effects. And I think one of the latest one is your Brintellix, vortioxetine, which is not in this list. So next question, how long would you recommend a patient with underlying major depressive disorder to continue taking his or her antidepressants? A, B, C, D, E. Is this wild guess? Okay, great. Lots of different answers until remission of symptoms. A, I guess. All right. Thanks. Thank you. Thanks. Everything is evidence-based, right? So let's look at what our CPG says. Our CPG quotes from a lot of different studies, so we will. It's quite good, quite reliable. So antidepressants should be continued for at least 6 to 9 months after remission of symptoms, like one of your colleagues mentioned earlier, and at least 2 years if there's high risk of relapse and recurrence. So if your patients have mild to moderate symptoms, first time diagnosed with a depressive episode, have no severe symptoms like self-harm or suicide, 6 to 9 months after remission, you can actually try to stop the antidepressants if the patient wishes to do so. However, if they have high risk of relapse, history of admissions due to depression, history of self-harm or suicide attempts in the past, at least 2 years. Yeah, so these are the numbers you would want to remember. Yeah, so this one we mentioned earlier, focus on just the one that's highlighted. So moderate to severe major depressive disorder, combined pharmacotherapy and psychotherapy. This combination should be offered to patients. This is a landmark study quoted by every psychiatrist everywhere in the world. So just focus on the one that is circled in red. So all antidepressants were more efficacious than placebo. So whether or not to start antidepressant if your patient is moderate to severe, or if you think they'll benefit even with mild to moderate depression, starting antidepressants always more efficacious than not starting at all. Always bear in mind to do also add in your pharmacotherapy and psychosocial intervention. Moving into, we finish our biological part, moving into psychotherapy. Yeah? So in our CPG, they recommended 3 different psychotherapy: your cognitive behavioral therapy, your mindfulness cognitive therapy, and your interpersonal therapy. So all these therapies can be done by your psychiatrist, can be done by your clinical psychologist, can be done by your psychologist. So if you do have a friend, a family, yourself, that suffering from depression or anxiety, you can actually request for this therapy as well. These services are provided in our government setting. We will focus mainly on cognitive behavioral therapy. Having said that, it would be a very brief run through, because later on in the afternoon, you will meet our clinical psychologist who would give a more detailed talk on what's going to happen in this therapy, and she will give you a practical session. Yeah, so that will be more helpful. So I'm just giving you a brief outline on what's happening. So only focusing on cognitive behavioral therapy. So in cognitive behavioral therapy, it's called cognitive behavioral therapy because it has to do with the mind and the behavior. But before cognitive came into play, the emphasis was only on the behavioral part. So the behavioral part is mainly your progressive muscle relaxation and also your deep breathing techniques. And I'm sure all of you have heard of this deep breathing exercise, right? So we are actually, if we do have time, we're supposed to do this together, but we don't have much time now, so I'm just going to do really quick. So basically, this deep breathing exercise is very simple. You just find a place that's comfortable, sit down, lie down, close your eyes, put your hands on your chest and one on your abdomen, because you want to feel the movement of your chest and your abdomen. So when you breathe in, your abdomen is supposed to rise. So your perut is supposed to buncit keluar. And when you breathe out, abdomen goes in. Wait. Chest rise, abdomen. Yeah. When you breathe out, abdomen goes in. Yeah. When you breathe out, abdomen goes in. Yes, correct. Yeah. So basically, different studies show the amount of different seconds that you actually do this. Some suggest 4 seconds, some suggest 7, some suggest 8. And it's actually whatever's comfortable for you. But the most important thing is that you do this routinely and habitually, because if you do this routinely and habitually, when you have an anxiety attack or when you have, depression, when you have a crisis and your thought is very muddled with all these preoccupation of negative thoughts. And when you do this with practice, it actually really helps. I'm talking very fast now. Yes. Later on, Ivana will go through all this with you. Fatin, how to manage patients who refuse it. Reduce dose of medication. I think in this case, every time there must be a very good therapeutic alliance between the therapist and the patient, because there is always a reason why patients do not want to be compliant with their medications. Number one, there's always a reason why patients want to reduce the dose of the medication. So if there is a good therapeutic alliance between the therapist and the patient, they'll be able to find out this underlying reason why. Because patients do not stop taking medications or do not reduce the dose for no reason. They might be side effects. They might be finding that the medication doesn't work. They might be finding sometimes the therapist doesn't actually help them much, so they don't have this therapeutic alliance with the therapist, so they act out on not taking the medications. So it's always good to find out the underlying cause why patients refuse to take the medications or off their medications. We are humans. We always tend to blame the patients, but sometimes it's good to sit down and take some time to think why they stop taking or why they reduce the dose, because there's always a reason why. Yeah. How would you advise patients who insist in self-titrating often, especially during this quarantine? Okay, I think the first part we addressed already. Sit down with the patient and find out the reason why. It's not always patient factor. Sometimes it's the therapist factor. Sometimes the therapist has counter-transference, and transference this problem with the patient, and it does act, and patients do act out on their medication. So find out the reason why. COVID-19, this was a big issue in the beginning. I think now it's a bit better, but there are still some patients who are paranoid to come over. Perhaps can work with, there are always other alternatives. You can always work with family. If patients are well and stable enough, can always get family to come over and collect medications after we teleconsult patients. Most psychiatric centers still conduct teleconsultation services. So if we call patients and patients are well enough, by all means, can always ask family to come and collect medications for them. If we call patients and patients are not well, there are different services we can mobilize. One is community service, where we go to patients' house and see how they're doing. If that is not convenient or they don't stay within our visitation zones, have to always, if they are very, very unwell, they still have to come and see us. Yeah, so try to work with your hospitals and see what services they provide. Cognitive part of cognitive behavioral therapy has a lot to do with your mind. So we believe that the thought determines our behavior and the behavior determines our feeling. That's why cognitive behavioral therapy targets a lot on our mind, because if we can control the thought, our thoughts, and if our thoughts are happy thoughts, it will cause us to be happy, and we do flip-flops like this, and it will bring a smile to our faces. Very simple diagram, right? Yeah, so simple example given here. Look, if we see a dog and your thoughts are, this dog will bite me, look at this cute dog, it won't bite you, right? Our feelings will determine our behavior. So if we start feeling afraid of this dog, we run away and the dog will chase us and bite our bums. But if we think that this dog is cute because it is really a cute dog, we will feel happy, and okay, we might not go pet the dog, but we will say hi to the dog, right, from far. So, our thoughts determine our feelings and our feelings determine our behavior, or vice versa.
My kind of analogy, Mervyn.
Huh? I
My
know.
kind of analogy. Thank
So
you.
You will go and pet the dog, I know.
I know.
Yeah. So grounding, this one Ivana will talk on because it's very practical. Yeah. So I won't touch a lot on this, but just remember that grounding is another technique that you can use. Question 4. Does diet or exercise have a role in the treatment of major depressive disorder and/or anxiety disorders? Every time you answer a question, it's a time for me to give myself a break. Okay, so C. Okay, great. Yeah, you guys are all correct. Studies have shown that both diet and exercise actually have a role in the treatment of major depressive disorder and/or anxiety. But what kind of food? There's this new field in psychiatry called nutrition psychiatry. Not very new, but not very famous yet. It's more famous in the Angmo countries. I think in Malaysia, because they recommend a Mediterranean diet. In Malaysia, we have our nasi lemak, all the carbohydrate actually is at the bottom. So our diet is quite the terbalik from this Mediterranean diet lah. But in overseas, in nutrition psychiatry, they actually recommend this Mediterranean diet, and more studies are emerging on how diet can actually influence those with major depressive disorder. A research comprising of about 10,000 students, university students, were done over a span of about 4.5 years. And it concluded that students who closely adhered to a Mediterranean diet had about 40% to 50% lower risk of getting depressed. Another study, the first RCT done using food to treat clinical depression, was also done around in 2017. And researchers actually sampled a group of university students who were already diagnosed with clinical depression. And these students were given a Mediterranean diet for about 3 to 4 months. And after this diet, concurrently with their antidepressants, it was seen that about 33% of them went into complete recovery over their depressive disorder. So yeah, your answers are right. Diet does play a role in actually helping people with depression, but not all diet, yeah, good diet like this. Maybe not the wine for us, just focus on the pyramid. Bear in mind that the lower part of the pyramid emphasizes on being physically active. Before we move on to exercise. So exercise plays a huge role as well. As you can see here, it decreases depression, it helps with postnatal depression, and it helps to also reduce mild to moderate anxiety and depression symptoms. So our CPG also encouraged us to actually put exercise as an adjunct treatment. International studies also encourage exercise to be adjunct treatment, and some even go to the expense whereby they say that it actually compares favorably to antidepressant medications as first-line treatment. Bear in mind, mild to moderate depression, yeah. So you can actually substitute exercise with your antidepressants for mild to moderate depression, according to this study. Anxiety disorders studies have been done, but doesn't actually show doesn't actually have that much an effective and cost-efficient, not so much, how do I put it? It's not been to red line here, not being shown to reduce anxiety to the level achieved by psychopharmaceuticals. Yeah, so for anxiety, not that effective. Exercise not as effective as compared to for depression. Okay, we're finishing. You can ask your questions later. Let me finish this first. Make some noise. So every person needs to do what they have to do to break the stigma. I think Dr. Amanda did talk about this earlier on. I think that's a very important point. And I'm always very happy when famous people come out to say, hey, I'm having some challenge. And not just famous people, but I think what Dr. Amanda did this morning, inviting a patient to share his or her real life experience having a mental illness is very important, because the more people make noise, the more people sharing their life experience with mental health actually helps others to step up and reach help for themselves. Thank you, Adele. Thank you, Beyonce. Thank you, Angelina Jolie. All these famous people have actually experienced mental health issues, namely depression, and actually have stepped out and reached out for help. Brad Pitt, Jim Carrey, Ellen DeGeneres, J.K. Rowling, Elton John, Dwayne Johnson, Inner Patrol. All these famous people actually have stepped out, and it actually helps people. They are actually a good influence because of them, they destigmatize mental illness, and more people actually are more aware of mental health disorders, and they actually are more daring and brave to seek help outside. So yes, I love this quote from Michelle Obama. We are all guilty of favoritism over our bodies as compared to our mind. The world today places so much value on the body rather than the mind. Just a while back, I was at a friend's house. Yeah, I know it's COVID, but we are all COVID negative. It's just a small gathering. And his daughter was actually brushing her teeth and on the sink on a small stool. And while she was brushing her teeth, I don't know how, she just slipped and fell. And the amazing thing is, once she fell down, she cried for a while, and Asian parents, being Asian parents, they just say, let her be, she'll be fine. So after she cried for like 30 seconds to a minute, she got up herself, and then she went to one of the dressing table's drawers. She took out a plaster and she pasted it on her wound. It wasn't such a bad wound, just very superficial laceration wound with some bruise. So I was so amazed, because at such a young age, she actually knew how to cover her wound to prevent infection and to stop the bleeding. It's amazing, right? We know all these since we were such a young age, 5 years old. But what do we know about maintaining our psychological health? What do we teach our children or our young relatives, nephews, nieces, regarding emotional hygiene? Unfortunately, nothing, right? We don't teach them emotional hygiene. We only teach them about, cover your wounds if you fall down. But what happens when they're emotionally hurt? We don't teach them. Why do we spend so much time caring for our physical health and none for our mental health? As a matter of fact, we sustain psychological injuries so much more often than physical ones. Failure, rejection, loneliness, betrayal, guilt, all these negative emotions can impact our lives in so much more dramatic ways. It is so common nowadays to hear someone telling another person who is depressed, to just shake it off, like what Dr. Amanda's talk earlier mentioned, just shake it off. It's all in your head. Just don't think about it. But is it that simple? Imagine saying the same words to someone who has a broken leg, It's all in your leg, just shake the leg off, just walk it off. We don't say that to those who have fractures, right? So why say that to those who sustain emotional and psychological injuries? It is time we close up the gap between our physical health and our psychological health. Not important, no time. Help. I think Dr. Amanda touched about this as well. So how do we help others? So I think that's what Laura has been planning this entire workshop. We learn about depression, we learn about anxiety, we learn about suicide, we learn about all kinds of mental illnesses so that we can help ourselves and people around us. We help them find support and professional assistance. I think Dr. Amanda did talk about this earlier as well. And I think what's so much more important is we take care of ourselves. I'm a huge advocate of self-care because I think if you don't care for yourself, if you yourself are unwell, if you're not at your optimal health, how can you care for others around you? So take care of yourself. You would not let this happen to your phone, so don't let it happen to you either. Self-care is a priority. It is not a luxury. I love the analogy when you go on planes. I love traveling. I love traveling. So, they always say if the oxygen mask drops down, put your mask on first before you help the person next to you. Same goes to self-care. You have to help yourself. You have to be optimally well before you can help those around you. So take care of yourself. So we are coming to an end, but before we close, we come to the single most important point of all, and that is how about you? How about all of you? How are you doing in this pandemic? Have you had any mental injury? Are you getting the support that you need? Does the community around you have services available? These questions will be addressed in the subsequent talks. Because look, just keep in mind that you are so not alone. There are so many people out there across the world even going through the same thing and thinking the same thing, but together we are really stronger. Depression and anxiety are treatable medical illness like cancer and heart, and don't ever feel alone. I'd like to end with this quote by Jessie J. It's healthy to admit you're not okay. It's okay not to be okay. It is actually very brave, but don't let it win. You be sad, have your moment, your day, or your week. Then do something about it and be happy for yourself. And with that, thank you so much.